Okay guys, obviously this is not how we plan to cover Unit 7, Chapter 14, but I am in the hospital in Odessa. Gave birth to Cora. She was 9 pounds 3 ounces, but she is in the NICU. She's having trouble breathing, so I will not be back for class. So I wanted to make sure that you had your information though, so we're going to cover Chapter 14. Now with Chapter 14, guys, we're looking at the sensory systems, and it's divided into two groups. Now both of these are discussed in anatomy too. We talk about the general senses, which are like pain, light touch, pressure, temperature, and proprioception. But we also talked about special senses, including taste, smell, sight, hearing, and balance. Now, in this presentation, we're going to touch briefly like on the pain, that sort of thing, because that goes along with a lot of the stuff we've talked about, because pain is one of the main reasons people come into the ER or go to the doctor. But also when we look at this with special senses, we're going to focus more on the sight, hearing, and balance, because those are more life-threatening. Taste and smell are not as big of a deal. So we're going to focus more on the sight, hearing, and balance. Now, in your book, there's a table 14-1. This is found on page 428. When we look at this, guys, this one talks about your general senses listed. It tells you what kind of stimulus it is and what kind of receptor picks up this stimulus. And the same thing goes with your special senses here in this chart. You'll notice that pain, especially, is a naked nerve ending. This is where the nerves are not covered in anything, and so the nerve ending. Special senses, taste is your taste buds. Smell is the olfactory cells. Sight is your retina, and your retina contains the rods and cones. Hearing is the organ of Corti, and balance, of course, is going to be those semicircular canals as well as the auricle and the saccule, both of which are going to help. We talk about semicircular canals, those are more with dynamic movements, like moving of your head, knowing where your body position is while you're moving. Auricle and the saccule are more for like static motion, where you're mostly just kind of sitting up straight, that sort of thing. So let's talk about some specific types of sensory receptors. There's mechanoreceptors. Mechanoreceptors are going to be activated by mechanical touch or pressure stimulus. They're going to also, mechanical receptors are what you see a lot of times with your stretch receptors. Chemoreceptors are activated by chemicals. This could be from the blood, food, or air. Chemoreceptors, guys, are part of your smell. Also your taste, they rely on chemical receptors. However, we've talked about throughout these chapters even some chemical receptors that aid in other body systems as well. Thermoreceptors are activated by hot or cold. Photoreceptors are activated by light. We have two types, rods and cones. And you have nociceptors. Nociceptors, guys, are activated by painful stimuli. Painful stimuli is also called noxious stimuli, meaning that it can cause damage or hurt. Okay, so you need to make sure you understand what nociceptors are. So let's talk about pain first. Pain is associated with many conditions. Most conditions we've talked about, there's going to be a lot of pain that comes with them. It is a protective mechanism. It's a mechanism your body uses to help protect from further damage or to also let you know damage has occurred. The most common reason that people seek medical attention is because of pain. It can be used to aid in some of our diagnosis. It's a subjective feeling, however, so every person's kind of perception of pain is going to be different. We see here that people have a pain threshold. Again, that's their perception of pain. Some people, this is going to happen earlier than others based on their, what we would also call their pain tolerance. Now, this can be influenced by a lot of things. We see here affected. This is emotion. This could be their emotional status, their behavior, their cognitive, that's going to be their beliefs, okay, or their attitudes. We see that there could be sensory issue because sometimes we don't realize we did something until we look at it and then we feel like we're in more pain. And there could also be psychological factors. Unrelieved pain can delay healing. Now the reason for this is it puts your body in a fight or flight response. Okay, it's acute stress response. The sympathetic nervous system kicks in, and so because of that we see that there's going to be a depression of the immune system. Now chronic pain, as it continues to develop, it's going to still decrease the immune system, but with chronic pain you see that the person develops a type of pain tolerance, where they can tolerate a certain amount of that chronic pain, but then if it exacerbates it, obviously it hurts worse, that sort of thing. Now with types of pain, somatic pain, this results from noxious stimulus to the skin, joints, muscles, and tendons. It's really generally easy to pinpoint where this pain comes from. Okay, you can say, oh, my knee hurts or my elbow hurts or things like that. Kids are really good about being able to tell you about somatic pain. Visceral pain, on the other hand, results from noxious stimuli into your internal organs. So sometimes the pain can be vague or it can diffuse over a certain area, so it's more generalized. One thing with this, though, too, is it may be sensed on body surfaces at distant locations from the originating organ. This is called referred pain. One of the best examples of referred pain deals with heart attacks. When a patient has a heart attack, a lot of times, sometimes their chest doesn't really hurt, it just feels heavy, but they have pain down their left arm. The pain down their left arm is going to be that referred pain. Now, focusing a little more on referred pain, we can see this picture here. It is found in your book. It's on page 430. It's going to show you where some of our referred pain is, and you'll notice that some of the places are very closely associated with where the organ is found. But if you look up towards like the neck area, there's some liver, gallbladder, lung, diaphragm areas. Obviously, that's not anywhere close to those. Referred pain originates at a visceral site, but it can be perceived as originating at a different body part. And normally it's going to be a body part that's still receiving information from generally the same type of nerves, coming out of the same, like maybe spinal nerve, cranial nerve. Sites of referred pain are determined embryologically. So a lot of times when we see here in the development of our nerves, the development of our tissues, there's going to already be places that are a little more interconnected due to embryological development. Now, some types of pain that your book discusses. There's phantom pain. Phantom pain exists after the removal of a body part, so something's been amputated, removed. What happens here is the neurons have been severed, and they may cause a spontaneous firing. The spontaneous firing goes up to the spinal cord, and they sense it as a normal sensation that hasn't been lost. So they might have where they feel like their foot's itching, but they don't have a foot. This can be extremely distressing to the patient because of the fact that they are already dealing with the idea of losing an extremity or losing that particular body part, and then they have pain from it. But it usually resolves with some time. We also see there's intractable pain. This is chronically progressing pain. This is relenting and severely debilitating type of pain. It does not usually respond well to most of our pharmacological pain treatments, and this even includes narcotics, your book says. This is common with severe injuries, especially if the injury deals with crushing injuries. Neuropathic pain is kind of like a subdivision of this intractable pain. It results from damage to peripheral nerves by disease or injury, and it tends to be chronic and intractable. So guys, remember that nerves, they don't regenerate, and so when they've been damaged to a point where they're constantly stimulated with pain, there's not going to be any way to maybe correct that. Alright, now guys, we're going to talk about some basic structure and functions of some of the special senses. So let's review the eyes real quick. The eyes perceive your environment, and there's a number of different structures of the eye. So I'm going to go ahead and switch to the slide with the picture, and I'm going to kind of stay there as I go through more of the structures so that you can have a picture view of it. This picture is found on page 431 in your book, figure 14.4. It shows you the structure of the eye. Now guys, the sclera is the white part of the eye, which you can see in picture B. The cornea is the lens on the anterior surface, so it's the front surface. The choroid is the middle layer of the eye, which contains melanin. Melanin, just like in your skin, is to help absorb light and help with protection. So here they're going to absorb it's going to absorb any stray light and help direct it towards the retina. Ciliary bodies, these are the anterior portion of the choroid. These contain smooth muscle fibers, and they help control the shape of your lens to help you be able to focus on what you're looking at. And you guys can see these in A. They're kind of the turquoise color in the picture. The iris is the colored portion of your eye. Sorry, let me go back to that picture. The iris is the colored portion of the eye. The pupil is the dark opening in the center of the iris. This is going to be the area that lets light in to be collected back on the retina. The retina is the innermost layer of the eye. It contains an outer pigmented layer and an inner layer consisting of photoreceptors and nerve cells. It's only weakly attached to your choroid though. This makes it very vulnerable to damage, and you can see this in the picture. If you look in the picture and follow the retina around, it only covers about 2/3 of the back part of the eye. It doesn't curve up towards the front, and so a lot of times you can see that this might peel away from the back of the eye, kind of like wallpaper kind of pills. They do contain two types of photoreceptors, rods and cones. Remember that rods are sensitive to low light and they function more at night. They're going to collect more of your shadows, your black and whites, whereas your cones only operate in bright light. They're going to give you more of your sharpness and your detail, and they're also going to be important for your color vision. The optic nerve, this forms from the axons of the ganglion cells that are at the back of the eye, and they collect into one nerve, and again it's the optic nerve. This area contains no photoreceptors and is insensitive to light because it's just collecting the information. Visual images are cast upside down on the retina, and then the impulses are transmitted to the brain where they're turned back right side up. We also see in this picture there's the lens. The lens is a transparent, flexible structure behind the iris. The anterior chamber is the front of the lens. The posterior chamber is behind the lens. The anterior chamber is filled with a watery liquid called aqueous humor. This helps provide nutrients to the cornea and the lens because both of those structures are avascular. They don't have a blood supply. On the back part of the eye, the posterior chamber, there's a type of fluid called vitreous humor. It's a clear gelatin type structure to it. It's going to be at a given level when you're born, and that's where it stays or it decreases. It does not get replaced. Conjunctiva, this is the fragile membrane that covers the inner surface of the eyelid and the exposed surface of the eye. We also see that we have lacrimal glands. These help keep your surfaces moist around your eye. So when you blink, it cleans the eyeball. It can sweep out fluid, sweep out stuff that gets into the eye. Tears drain into the inner side of the two lacrimal ducts. And you can see there that it's labeled. It's going to be this little pinpoint in the corner of your eye towards your nose where fluid can drain. Okay, so this is looking more at just the basic structures of the eye. As we go through this, we're going to see when there are certain issues with different parts. Now let's look at the ear, the structure of the ear. Now guys, the ear can detect and process sound. It detects your body position. But guys, it's not only going to help you with sound, but your ear helps you with balance and position. The ear is divided into three main parts. The outer ear, this is the auricle or the pinna. This is called also part of the earlobe, and it's the external ear canal. The middle ear is the tympanic membrane and the ossicles. Remember, the ossicles are three small bones. And the inner ear, this has the cochlea, the semicircular canals, the saccule, and the auricle. So again, guys, this picture is found on page 433 in your book, 14.6. There's also a table that reviews all of these structures on 14.3, which is on page 434. So we're going to kind of stay here because we'll talk about how sound gets transmitted into the ear here. Sound is going to enter through the auricle, and remember the auricle here is an irregular shaped cartilage and it channels sound into the ear. Sound then travels through the external ear canal until reaching the tympanic membrane. We call this the eardrum as well. This begins part of the middle ear. The vibrations transmit from the membrane to the ossicles. Remember, the ossicles are the malleus, incus, and stapes, also known as the hammer, anvil, and stirrup. The malleus lies near the tympanic membrane, and when the tympanic membrane vibrates, it causes the malleus to vibrate. The malleus then comes in contact with the incus and causes it to vibrate, which then the incus comes in contact with the stapes. The stapes then comes in contact with what we call an oval window, which connects the middle ear to the inner ear. These vibrations that are created by the tympanic membrane will amplify as they are transmitted through the structures of that inner ear. Movement of the oval window causes fluid from within the cochlea to vibrate, and it creates a type of waves. The organ of cordia is also known as the organ of hearing. It contains hearing receptors, the hair cells, and they vibrate. When they vibrate, it stimulates that hair movement. Dendrites then wrap the bases around these hair cells. Hair movement causes the dendrites to form nerve impulses. These nerve impulses travel to the brain. Once they travel to the brain, they can do it through the vestibular cochlear nerve. This is nerve 8. The part of the ear is important for position and balance. This is the inner part of the ear. It has the vestibular apparatus. The two parts we kind of talked about a minute ago, the semicircular canals and the vestibule. The semicircular canals have all of the rings and they have fluid in them. This is also help with the movement of your head, knowing your body position. Helps keep you kind of from getting dizzy and that sort of thing. The vestibule is a bonier chamber, and this is going to be more for your body position and static motion. Both of which are important for balance. And so some of the stuff we'll talk about today is where these are kind of hindered. Also in the ear, guys, there's the eustachian tube. It's located in the middle ear and opens into the pharynx, remember, is the throat. This acts as a pressure valve. This pressure valve is normally going to be closed. However, if we need to maintain a certain pressure within your middle ear, this tube will kind of open up when you're yawning or swallowing. Opening the eustachian tube allows air to flow in and out of the middle ear, equalizing it. This is what we would call it kind of popping of your ears when you go and you fly and you go to a higher altitude. This is to help protect your tympanic membrane or your eardrum. Alright, so that was the normal function that we saw in all these structures. So now let's focus more on the abnormal. And guys, on your notes, I don't really like how the chapter did this, but I tried to stay with the chapter where it jumps back and forth between eyes and ears. But just bear with me, we'll go through them. Anytime we're altering a sensory condition, there's a bigger risk for injury. That's the big thing you need to know. This could be for pain because maybe they don't feel pain like they're supposed to, so there's higher risk. They can't see it because there's a problem with their eyes. They have disturbed balance. There's just higher risk of injury. So that's the main thing you need to know about sensory. Alright, so the first one we want to focus in on is the eyes, and this is the congenital cataracts. We're going to hit on cataracts again a little later, but this one's congenital, meaning they're born with it. It's a clouding of the lenses that is present at birth. It results in a hazy type of vision. In most cases, there's no specific cause that can be identified of why the child was born with these cataracts, but they could be associated with several genetic disorders, especially chromosomal problems like Down syndrome, Patho, Lowe syndrome, and Glaucoma. However, we also see that it could be due to an intrauterine infection exposure, like the mom was being introduced to rubella and the baby got it, and so it causes congenital rubella, which could potentially cause the cataracts to form. Other manifestations are failure to demonstrate visual awareness or presence of nystagmus. Now, nystagmus, guys, if you want to Google that or YouTube it to kind of see what it looks like, it's where it's rapid movement of the eyes. We see there's also going to be with diagnosis, history, physical examination, and this is going to be an ophthalmology exam, and this is going to be unique just for babies. It's not going to be like, which one's better, 1 or 2, like we would normally do. But additional tests may be necessary to determine other things that could be associated with their condition. Treatment may not be required. It could potentially clear up as they grow out of it, especially if it's like an infection or something like that. There could be a surgical removal, artificial intraocular lens could be put in, patching, or they could be just management of the underlying disorder. Alright, now let's talk about some congenital ear conditions. Some congenital ear conditions contain Anotia. This is the absence of the auricle, so meaning there's no outer ear that's present. Microotia is the underdevelopment or a small auricle that's there. And Otitis is a lack of the external ear canal, all of which are manifestations where there's not correct development of that outer part of the ear into the middle ear and inner ear. These conditions are more common in males. Most often associated with congenital conditions affecting the head. So a lot of times, like if it's going to be something that causes the head to be smaller or issues with development of the skull structure itself, it's going to affect this structure because this is one of those openings that goes into the skull. It may be unilateral or bilateral, so one ear or both. Congenital hearing loss can occur because of the damage, and this is a lot of times because they can't, there's no conduction of sound into the middle or inner part of the ear. It could also be associated with maternal rubella or syphilis infections that occur during pregnancy. In your book on page 438, you can see the examples here. A is a picture of Anotia. This is no ear canal that you can see. And then B is microotia. It's small, decreased in size. Now, sensory conditions associated with age is what we're going to talk about next. So we're switching gears. We went from being born with it, now as we age and get older. The senses become less acute. This means they're less able to distinguish details. Aging increases the threshold needed to perceive an actual sensory input. So because of that, the amount of the sensory input needed has to be greater. It's kind of like how they can't hear, so you kind of have to yell at them. There's physical changes that account for most of the other sensation changes. So let's talk about some of these. Alright, this is going to focus more on the eyes. This is age-related eye changes can begin as early as age 30. These eye changes include less tear production. We could have actual structural deteriorations of the eye itself. The corneas become less sensitive. The pupil size decrease and they react more slowly. Lenses can become yellowed. They're less flexible and slightly cloudy, so they're not sending the light back to the retina like they're supposed to and focusing as well. Fat pads supporting the eye can decrease, and the eyes can actually sink back into the skull, affecting their structure. Eye muscle weakens. This decreases the ability to rotate the eye fully, can limit your visual field. Visual acuity may gradually decline. A lot of times you're going to see a decrease in night vision first, and also distinguishing between light colors. Presbyopia is the difficulty focusing the eyes. This is going to be seen a lot of times in older patients, which can then lead to other eye issues. Treatment is glasses or contact lenses. They may use red lighting and lowering the light to also help to not overstimulate or things like that, but that may be what they use for treatment. So let's talk about some ear issues with age. All the ear structures thicken with age. This can affect your balance and your hearing. Hearing may decline slightly, especially with high frequency sounds like higher pitches. Hearing loss accelerates in people who are exposed to excessive noise or smoking when they are younger. So excessive noise is like when they have their earphones in and you can hear it like down the hallway. That's too loud. Presbycusis, this is age-related hearing loss. They first lose the ability to understand speech. Hearing acuity may decline slightly beginning around the age of 50. Possible causes caused by changes in the auditory nerve. The brain may have a slight decreased ability to process or translate sound into meaningful information. This is seen a lot of times with your patients with dementia, or if there's some sort of maybe brain trauma in that area. Some other issues with aging, when we talk about hearing, we could have impacted cerumen. This is earwax. It's another cause of impaired hearing. It's more common with increased age. There's two types of hearing loss. There's sensory neural hearing loss. This involves damage to the inner ear, auditory nerves, or the brain. So it's going to be more of the nerve track. The conductive hearing loss occurs when the sound has problems transmitting from the outer, middle to inner ear. This is where the sound is not actually being conducted through there. The sound's going to travel through waves first, then nerve impulses. Tinnitus, this is very common, and this is ringing of the ears. Some treatment is surgery or a hearing aid may help for conductive type of hearing loss, but again, it depends on the specific cause. Alright, switching back to the eye, on page 439 that talks about conjunctivitis. This is an infection or an inflammation of the conjunctiva. This is caused by virus, is most common. However, bacterial infections can cause this, like Staphylococcus, chlamydia, or gonorrhea. Allergens can also be the culprit, like pollen and dust. Chemical irritants and trauma can also be an issue. Can generate blurry vision and photophobia, not liking the light. Viral infections normally produce a watery or mucus-like exudate, whereas the bacterial side of the infection may produce more of a yellow or green exudate. Allergens and irritants typically produce redness, itching, and excessive tearing. Risk factors could be wearing contacts, using contaminated makeup like eyeliner, or ophthalmic medications, like if you're using eye drops and you share and things like that. Bacterial and viral conjunctivitis is very contagious, and it's contagious through direct contact. Treatment. Many resolve without treatment. It varies depending on the underlying agent, of course. This could be that they might use antibiotics or antivirals if the infection's bad enough. They do treat infants' eyes with antibiotics shortly after birth. Then the reason for this is to help prevent any kind of infection. And also you could use warm, moist compresses. Alright, The next one that we can look at for an eye issue is keratitis. This is found on page 439. It's an inflammation of the cornea, and it can be triggered by an infection or due to trauma. The herpes simplex virus type 1 can actually be the main culprit of this. It's where it's self-transmitted from the mouth up to the eye, and this is caused by the ulcerated form like cold sores. Manifestations, of course, are severe pain, photophobia, and visual disturbances. The treatment's going to vary, and it's going to vary depending on the underlying etiology or cause, but it does include ophthalmic or oral antibiotics, so you may have to have drops that have antibiotics or even take them, on corticoid steroid agents. The whole point of this, especially if it's a viral infection, is to prevent viral replication in the cornea. We also don't want blood vessels traveling into the cornea, because the cornea is supposed to be an avascular structure. Now switching to the ear, we're going to look first at the Otitis Media. This is a middle ear infection or inflammation. This is what we normally would say is an ear infection. It's a common condition in young children. A lot of times this is because the eustachian tube of a young child is narrower and straighter. It's shorter than those of adults and older children, and so the bacteria can travel up there quicker, and their immune system is more immature and it's harder to fight it. Additional causes could be fluid accumulation in that middle ear. This could be due to adenoid enlargements, but it's usually due to inflammation. This type of infection is more common in the winter months. Fluid collection from viral infection provides a prime medium for secondary bacterial infections. You have to be careful of that. The secondary bacterial infection is normally Streptococcus pneumoniae or Haemophilus influenzae, both of which, however, are bacterial infections. Additional risk factors, if a child's put into child care, if they're in group settings, if you feed an infant supine completely laying flat instead of elevated, environmental smoke exposure, a history of allergic rhinitis, that's going to just be normal hay fever allergies, premature birth, or even ethnicity can be a risk factor. Complications, rupture of the tympanic membrane can be very painful. The tympanic membrane can heal, but that scarring tissue could potentially hinder hearing. It could be scar tissue formation, conductive hearing loss, mastitis. Mastitis, guys, is where the inner ear infection or the middle ear infection turns into a bigger infection because it spreads to the bone of the mastoid. Could also cause cholestostomia. This is an abnormal skin growth in the middle ear behind the eardrum, which again, of course, is going to cause the ability of conduction of sound to be a problem. Meningitis and osteomyelitis. Remember, osteomyelitis is infection of the bone. And the middle ear is the one that has those little ossicles. Manifestations are ear pain, crying or irritability, rubbing or pulling on that ear, mild hearing deficits. They could have sleep disturbances, red and bulging tympanic membrane, indications of infection like purulent or clear exudate from the external canal. The eardrum itself could be ruptured, nausea, vomiting, or headaches. The diagnosis. Guys, this picture is found on page 441, and it's going to be more for treatment, but a diagnosis is going to be a physical examination, history, otologic examination. They'll visualize and look at the tympanic membrane with an otoscope. They also may use an acoustic refractory type of test to see how hearing is going. Treatment is oral or otologic antibiotics. That's going to be like drops that go into the ears, and painkillers, oral decongestants and antihistamines, especially if it's going to be based on allergies, or it could even be based on a head cold. Antipyretics, wanting to keep the fever down. Tympanosectomy tubes, that's what you see here in the picture. These are what we call ear tubes. And also there could be removal of the adenoids if they're very enlarged. The next group we're going to look at is the Otitis Externa. So now we're moving to the outer part of the ear. When we look at the outer part of the ear, there's infection or inflammation. Usually there's going to be a bacteria that causes it, and the bacteria that's most often shown there is Pseudomonas aeruginosa, but there can also be fungal. Generally, it rises from moisture put in the ears, and it creates an environment for bacterial or fungal growth. Risk factors. A lot of times this is also called swimmer's ear because swimming in contaminated water can cause the problem. Scratching outside or inside of the ear, insertion of foreign objects because that can introduce new bacteria. Complications are hearing loss, cellulitis, necrosis, osteomyelitis, and meningitis. Manifestations, of course, are ear pain that worsen with auricle movement, purulent exudate, itching, a sensation of fullness in the ear, and hearing deficits. Diagnosis again, guys, we're going to see history and physical examination. They'll do an exudate analysis. This can help them determine whether it's a bacterial infection or a fungal infection. Treatment, we want to put antibiotics or antifungals. We also may need to use corticosteroids, painkillers. We want to clean the external ear canal. One way to do this, guys, is to bathe it with alcohol-based products. The alcohol can help dry up any water that's in there. But also you have to be really careful too. Don't put in like Q-tips and things like that to clean it out. Just pour the water in there or the substance in there to clean it out. Drying the ears after swimming is important, or bathing with an alcohol-based product. Avoiding insertion of foreign objects into the ear, and also treating pulls properly is super important. When we look at eye trauma, this is caused by a direct physical trauma or chemical burn to the eye. It may vary in severity from mild, like a black eye, to sight-threatening, where we have a corneal abrasion or closed-angle glaucoma. Vision deficits often result, but again, it depends on how quickly treatment is received. Manifestations: eye pain, edema, blurry vision, diplopia, this is double vision, dry eyes, photophobia, not being able to see real well in light, floaters, pupil dilation, and pupils that are non-responsive to light. Early diagnosis and treatment can prevent or limit the severity of the visual defect. Diagnosis, history, and physical examination are important. And again, of course, this will also be where you might need to go see the ophthalmologist for an ophthalmic examination. Treatment. You may need to flush out the area. This is one thing that we do when stuff gets in the eye in the lab, is you want to remove the irritant, and so that's why you have like an eye wash or something like that. But we want to avoid rubbing, because rubbing can potentially cause more damage. If something is embedded in the eye, we may need to leave the object in the eye and then just cover it with a sterile dressing or cloth until further assistance can be given. Applying an eye patch to protect the eye during the healing process could be important, and then also repairing any damage surgically. If there's ear trauma, this could be direct physical trauma to the ear. This could be due to foreign objects that are in there, or insects. Excessively loud noises like explosions and gunshots can do this as well. Can result in permanent hearing deficits. Bloody or clear exudate may be present, ringing of the ears, dizziness, ear pain, hearing deficits, nausea, vomiting, edema, and a sensation that an object is in the ear. Treatment. If there is an object in the ear, we should remove it. And this is easier said than done, because you don't want to cause further damage. Performing surgery to move the object or repair the damage might be necessary. And also limiting exposure to loud sounds as the structures heal is important. Alright, now let's switch gears to glaucoma. We're looking at glaucoma. This is a group of eye conditions that lead to damage to the optic nerve. A lot of times glaucoma you hear about with treatments using marijuana, but this is because the optic nerve is what's damaged. Increased intraocular pressure is the culprit, and decreased blood flow to the optic nerve results because of that. Pressure inside the eye can climb because of blocked outflow of the aqueous humor, so we could be having proper amount of fluid, but it's not flowing out, and so it builds up. Or there could be an increased production of the actual aqueous humor. This increases pressure, causing ischemia and degeneration of the optic nerve. This is the second leading cause of blindness. The first leading cause is diabetic retinopathy. The second leading cause is glaucoma. So let's talk about the different types of glaucoma. The first one's an open angle glaucoma. Intraocular pressure increases gradually over an extended period of time, and this is the most common type. Risk factors: family history, having African American descent. Manifestations of this type of glaucoma is pretty painless. It's insidious, meaning gradual. There's bilateral changes in vision. They may have what we have: tunnel vision, blurred vision, halos around lights, especially at night, and decreased color discrimination. Closed-angle glaucoma, however, is a medical emergency. This is not going to be where just the production is messed up. This is going to be something is blocking the aqueous humor outflow. This could be caused due to trauma, sudden pupil dilation, like exposure to bright light or prolonged exposure to darkness, prolonged pupil dilation. This could be medications that can be given during medical exam or eye exams when they are dilated, or even emotional stress. Typically unilateral and affecting one eye, but it may affect both. It's sudden and severe eye pain, headache, nausea, vomiting, a non-reactive pupil in the eye affected, redness, haziness of the cornea, and vision changes like halos around the lights. Congenital glaucoma is present at birth. This is results of abnormal development of outflow channels. A lot of times the trabecular meshwork of the eye may be malformed, not allowing the fluid to drain properly. This could be an X-linked disorder, recessive, meaning it's going to affect males more often. It may go unnoticed for a few months. Manifestations, they could have excessive lacrimation, meaning excessive tear production, photophobia, corneal edema, white or gray-white appearance to the cornea, enlarged eye globe, and also vision deficits. Secondary glaucoma results from certain medications, and a lot of times corticosteroids could be the problem. It could be an eye disease like uveitis or nearsightedness, systemic disease like arteriosclerosis or diabetes, but it's normally going to be caused by something else, like a different disorder, and one of the side effects is secondary glaucoma. Now, in your book, guys, there's some pictures that kind of shows you how this works. 14-14 on page 443. In A, it shows you the normal flowing of aqueous humor in that anterior chamber of the eye, the front chamber of the eye, and that's A on both sides, okay, of the pictures. B is going to be showing you the open angle glaucoma. This one's the one that's kind of slow rising, but there's a buildup of fluid on the in the anterior portion, and it could just be due to an excessive amount. We also see then the C is where there's an actual blockage. The fluid cannot drain properly because it is being actually blocked in the process. Diagnosis, history, and a physical examination. Ophthalmic examination, including what we call a gonoscopy. This is the front, looking at the front part of the eye, and it's going to help to distinguish if it's an open or closed angle type glaucoma. Optometry, this is where they're going to measure pressure within the eye. Optic nerve imaging, pupillary reflex response, retinal examination. Slit lamp examination, again to focus in on the front part of the eye. Visual acuity testing, and visual field measurement. Now guys, treatment. There's a lot of types of treatment that can be given here, and here's a ton of types of medication. All of these medications are going to help reduce pressure, intraocular pressure somehow. Some of them, like beta blockers, is just going to decrease the pressure of the fluid. The alpha anginists, these are going to increase outflow and decrease production of aqueous humor. So a lot of them are going to do one of two things. Okay, they may decrease. They're going to decrease the pressure, but it could be by decreasing the amount of fluid being produced, or by increasing the amount of fluid that is absorbed. We also see, though, that these oral medications are not normally affected by themselves. We need some other stuff that needs to come in here, and we can see that there's other medications that are part of this. There's also laser surgery. These laser surgeries are to open up the aqueous humor outflow. Filtering surgeries, drainage implants, all of these have to do with, like, if there's a clogged canal or something, that's to help open up the area to increase drainage again. The main strategy for closed angle glaucoma is a radiotomy. What we're talking about here is where they use lasers around the iris. It punches holes in it. This allows fluid to move from the anterior chamber to the posterior chamber, relieving some of that pressure. The main strategy for treating congenital glaucoma is surgery to open up the aqueous humor outflow channels, because a lot of times, remember, it's that meshwork that's messed up, so they can use a laser, filtering, or drainage implant. Strategies to treat secondary glaucoma. First thing you got to get under control is the chronic disease. If it's diabetes, get diabetes under control. If we can treat and eliminate the underlying disease, that's even better, but a lot of them aren't going to be able to be done. Previously diagnosed glaucoma, pharmacological and surgical treatments could also be used for secondary glaucoma. Alright, our next group is the cataracts. With the cataracts, opacity and clouding of the lens takes place. You can see this in the picture. You can see how it's causing a kind of film on the cornea. This is on page 444. It can occur as a congenital condition, which we just talked about, or it can develop later in life. Risk factors with the adult onset cataracts is family history, advanced age, smoking, UV light exposure. This could be natural or artificial. Metabolic conditions like diabetes, certain medications like corticosteroids, and eye injuries like trauma or infection. Many affect one or both eyes and do not necessarily affect the eyes symmetrically or the same way. Other manifestations: cloudy, fuzzy, foggy, and filmy vision. It's got vision distortion, which you can see here in the picture, how the outer edges are fine, but the inner part you can't really see what's going on. Color intensity loss, diplopia, impaired night vision, gradually progresses to impaired day vision, halos around lights, photosensitivity, frequent changes in eyeglass and contact prescriptions. Diagnosis is history and physical examination. Again, you may have to go to the ophthalmologist, look at visual acuity testing, retinal examination, and a slit lamp examination. Treatment: if the cataracts are bad enough, guys, you use surgery. We get cataract transplant and managing or eliminating contributing factors. The next group is macular degeneration. This is a degeneration of the macular area of the retina. It's caused by impaired blood supply to the macula. It results in cellular waste accumulating, and also ischemia because we're not getting oxygen to the area. The most significant risk factor of this condition is advanced age. There could be other risk factors like a family history, being female, Caucasian descent, smoking, high-fat diet, and obesity. There's two types of macular degeneration. There's dry and wet. Dry occurs when the blood supply or vessels under the macula become thin and brittle. So there's no blood getting to the area. This is why it's called dry. Small yellow deposits called drusen form under the macula. Deposits increase in size and number, blurring the vision and creating a dim spot in the central vision. Almost all people with macular degeneration start with the dry form. Progresses generally over years. The wet macular degeneration occurs in only about 10% of the people with macular degeneration. Brittle vessels will break down and new abnormal fragile blood vessels grow under the macula. These vessels leak blood and fluid, leading to macular damage. This one's not as common, but it causes most of the vision loss associated with the condition. It progresses slowly with rapid vision loss over weeks or months. It progresses suddenly with rapid vision loss over weeks or months. Alright, a diagnosis is going to be history and physical examination, ophthalmic examination, including visual acuity, using the Amsler grid. Guys, this is where it's like a grid and there's a dot in the middle and you focus in on the dot, and if any of the lines start to wave, go missing, or go blurry, then obviously you could have some problems. Retinal examination, Florentine angiogram. This is to study the blood flow to the retina and the choroid, and also the optical coherence CT or optical CT scan. Macular degeneration treatment. No treatment exists for dry macular degeneration. There is a type of formula that might help slow it down. This is called age-related eye disease study formula, but smokers should not take this. Okay, it's 500 milligrams of vitamin C, 400 intestinal units of beta-carotene, 50 milligrams of zinc, and 2 milligrams of copper. They found that this combination kind of helps. There's also no cure for wet macular degeneration. So strategies may include laser surgery, photodynamic therapy, anteliogenesis or antivascular endothelial growth. This is the whole idea of stopping the spread of those small vessels. Low vision aids, and also occupational therapy. Osteosclerosis is abnormal bone growth in the middle ear, usually involving an imbalance of bone formation and reabsorption. The cause is unknown, but there could be a link to heredity. Abnormal sponge-like bone grows in the middle ear. This prevents the ear structures from vibrating in response to sound waves. It causes conductive hearing loss. This progressively gets worse as they first lose the ability to hear a whisper, and then it continues because the bones are not vibrating like they're supposed to. Nerve loss can also occur in this state, most common in young adults, women, and Caucasians. Pregnancy may also trigger this. Typically affects both ears, and also ringing of the ears may be present. Diagnosis: history and physical examination. This includes hearing test, temporal bone CT scan. With treatment, medication of oral fluoride, calcium, or vitamin D may help to control the hearing loss. But we need to look at what the underlying cause is. Hearing aids to treat the hearing loss. Surgery to remove the stapes and replace it with a prosthesis. This is a stapedectomy. They can also use laser surgery to create an opening in the stapes with or without the replacement of the prosthetic device. Another hearing issue is Meniere's disease. This one doesn't always just affect the hearing, but it also affects balance due to being in the inner ear. This is where the inner ear gets inflamed and it results from endolymph swelling. The swelling stretches the membranes and interferes with the hair receptors on the cochlea and the vestibule. The exact cause is unknown, but it might be associated with head injuries, again, middle ear infection, and syphilis. Additional risk factors: if you have allergies, alcohol consumption, stress, fatigue, certain medications like aspirin, and respiratory infections, you're more prone to develop this. Manifestations typically occur in a wave of acute episodes that last several months, followed by brief periods of relief. Attacks are triggered by changes in barometric pressure of any of the following. So you can have intermediate episodes of vertigo, tinnitus, unilateral hearing loss, and sensations of fullness. Complications, of course, are permanent hearing loss. Diagnosis: we have history, physical examination. This includes a neurological assessment, hearing test, balance test, electrocholiography. We talked about electrocholiography. This is going to be where they record electrical impulses from the inner ear to the auditory nerve. That's what normally carries the sound. We also see that they have electrostalmography. This is where they're going to record eye movements, and they're going to see if the patient complains of vertigo, balance issues, or dizziness. They can do a head CT scan and also a head MRI. Treatment: there's no cure. However, there's a lot of medications listed here. They believe that they want to try to bring the number of patients down. So what they do is they take these neurotransmitters, they hide them away in the Arizona desert, and they work to decrease the number of people that have this disease per year. We also see one of the other main ways to treat this is to limit the dietary sodium intake, because when you have a lot of salt, excess salt, it can promote fluid retention. Also, avoiding triggers like alcohols and stress, middle ear infections, corticosteroids, partial or complete surgical removal of the endolymph in the inner ear, vestibular nerve resection, like you've removed part of that nerve, hearing aids, and physical exam to improve balance. This brings us to eye cancer. This is actually very uncommon, affecting genders and ethnic groups relatively evenly. It can affect any part of the eye. The most common intraocular cancer in adult is melanoma and lymphoma. The most frequent eye cancer in children is retinoblastoma. With eye cancer, it may metastasize to the eyes from other parts of the body. Manifestations: some sort of visual disturbance happens, losing part of their visual field and seeing flashing lights. Diagnosis: a family history, ophthalmic exam, ultrasound, fluorescent angiography, imaging the blood vessels of the eye, using that contrast dye. Treatment: surgery, radiation, and a prosthetic eye. Strabismus is a gaze deviation of one eye. The eyes do not coordinate to focus on the same image together, resulting in dioplia. Most often appears at birth or shortly after. In children, the brain will begin to ignore the input from one of the eyes. So if the brain continues to ignore one eye, the eye will never function properly, and permanent visual deficits may occur. This can be amblyopia, which we'll talk about in a minute. So it needs to be taken care of. Causes: it can be caused by a weak or hypertonic eye muscle, short muscle, or a neurological defect. Most often it's associated with a chromosomal defect like we see with Down syndrome, or an intrauterine infection exposure like congenital rubella, eye cancers like retinoblastoma, or traumatic brain injuries. Diagnosis is history and physical examination, and that also includes an eye exam as well as a nerve exam. Treatment are glasses or prism glasses, eye muscle exercises, eye patching, and surgery. Again though, catching this early and correcting it early is the key. Amblyopia is the loss of one eye's ability to see details. Most common cause of vision problem in children. This occurs when the brain and eyes do not work together properly and the brain favors one eye. The preferred eye has normal vision, but because the brain ignores the other eye, vision does not develop normally. Okay. Normal eye attempts to the normal eye attempts to compensate for affected eye. This creates a vicious cycle where the normal eye becomes stronger and the affected eye becomes weaker. The brain stops growing between the ages of 5 and 10, at which time the condition can become permanent if treatment has not been done. Strabismus is a family history, bilateral astigmatism, congenital cataracts, farsightedness, and nearsightedness. History and physical examination include ophthalmic examination. Treatment is wearing glasses, eye muscle exercises, eye patching, ophthalmic medication can also be part of this, and surgery. Is it reversible? Well, it depends on the maturity of the visual system at the time of onset. If it's a very immature visual system, it has more time to recover than one that has been matured. The next one I want to talk about, and I believe this is the last one that relates to the eye, is a retinal detachment. This is an acute condition that occurs when the retina separates from the supporting structures. Its cause can be spontaneous. It could be due to severe nearsightedness, trauma, diabetes, inflammation, degradative aging changes, and scar tissue. It occurs when the vitreous humor in that posterior chamber starts to leak or deteriorate through a retinal tear, and it accumulates underneath the retina. Now this doesn't help because the vitreous humor is only going to have a certain amount and it doesn't get replaced. You can also see here the folding and clouding that you see happening. This is what's happening. The retina is pulling away from the edge. Leakage can also occur through tiny holes where the retina has thinned due to aging or other retinal disorders. Less commonly, fluid can leak directly underneath the retina without a tear or break. As vitreous humor collects underneath it, the retina peels away from the underlying corticoid. These detached areas may expand over time. The retina becomes ischemic and stops functioning, causing vision loss. So manifestations, guys, this one is typically painless. However, it's still a medical emergency. We see flashes of light in the peripheral visual field, blurred vision, floaters, and even darkened vision. This darkened vision is really important because it can cause changes in mobility. Diagnosis, history, and physical examination. Eye examination. Again, focusing on the retina and also the intraocular pressures that are there. They also are looking for color discrimination, visual acuity tests, slit lamp tests, and eye ultrasounds. It is a medical emergency, so treatment should be given as soon as possible. There's a number of ways that this can be treated. We see that they can include what we call chiroplexy. This is intense cold application to the area with an ice probe to form scar tissue, which holds the retina to the underlying laser. Laser surgery to seal the tears or holes in the retina. Pneumatic rhinopexy. This is placing a gas bubble in the eye to help the retina float way back into place. Sacral buccal indents the eye through the eye wall, and vitrectomy, removing the gel or scarring tissue, pulling on the retina, and then replacing it with something. Tinnitus is hearing abnormal noises in the ear like ringing, buzzing, humming, whistling, roaring, and blowing. This may be associated with presbycusis. This is that aging of the ear. Exposure to excessive noise, cerumen impactation, otosclerosis, Meniere's disease, stress, head injury, acoustic neuroma, arteriosclerosis, hypertension, choroid stenosis, intravenous malformation, caffeine, autotoxic medications, many antibiotics, aspirin, chemotherapies, and diuretics can cause this. Diagnosis, history, and physical examination are important. They use these tests to identify the underlying cause, which then is going to determine the type of treatment. We need to treat the underlying cause first. Then we can use the next three as medications that show to work against this. However, they also show that white noise machines and hearing aids can help overcome the area or the sounds that you do hear, avoiding things that can worsen this, like diet with caffeine, smoking, autotoxic medication. The last thing I want to talk to you guys about is the vertigo. Vertigo is an illusion of motion. It's not the same as dizziness. It just means that it looks like the room is spinning. Peripheral vertigo occurs when there is a problem with the vestibular labyrinth, semicircular canals, or the vestibular nerve. Causes could be certain medications like antibiotics, head injuries, Meniere's disease, nerve compression, infections, and inflammation. Central vertigo occurs when there's a problem in the brain, particularly in the brainstem or cerebellum. This is where the information gets sent, but then it gets perceived incorrectly. Arteriosclerosis can be part of this. Certain medications like anti-seizure agents and aspirin, alcohol, migraines, multiple sclerosis, and seizures. Additional manifestations of this group is going to be nausea and vomiting. So with diagnosis, history, physical examination, and other tests to determine the underlying etiology or cause is important. We also see that we can use different types of agents for this medication-wise. However, safety precautions are super important with somebody with vertigo. Sometimes if it's a structural issue of the inner ear with vertigo, it can be treated with physical therapy. Okay, so this just covers some of those those sensory neuro issues like sight and hearing, as well as balance. Please view this video, review it, go through, read your book, make sure that you're taking your quizzes, turn in your case studies, and we'll keep you guys posted on class. I believe out of the next 3 weeks you'll have to come to one of the classes, and then you will also then have to come, of course, for your final exam. Again, I will be posting a final exam review video. If you have any questions, please feel free to email me.